Gary Jacobs, thank you so much for joining me today.
My pleasure, Austin.
I guess, do you want to start off with a little bit about you and your background?
Yeah, so I'm a health policy guy. I've been doing this work both from the operational side of being an entrepreneur and starting healthcare businesses, always at the intersection of public policy and business opportunity, always knowing that the government can only fund so much and that the innovation may start at the federal level, but it really comes from the private sector and private sector investment in ideas. And I've always tried to balance the two. And over time, after a successful career, primarily in the jungle of South Florida, eventually moved to DC, where I had gone to graduate school and knew I'd be back at some point in time. Didn't know the capacity, but was working for a company called Universal American, which was one of the newbies compared to the established players in Medicare Advantage and Part D. So we were a med sub company that kind of converted to a Medicare Advantage company and blew up as an organization in a good way in growth, and went from NASDAQ to New York Stock Exchange, all those things that happen when you grow that fast. And it was fun. It was exciting. And I was on the Hill representing not only our company, but all the payer companies in being an advocate for Medicare Advantage. And that worked out fairly well in that moment in time. And then over time, moved to the provider side and became very involved with primary care, worked at a company called VillageMD, and VillageMD was a vision we had of what primary care led risk-bearing physician groups might look like if done correctly. And we were creating as we went along what correctly might mean, and gone through the ups and downs, really got focused with CMMI when Adam Bowler announced a direct contracting program. And we were one of the initial participants in that program, really thrived in it because our organization was structured to be like a risk bearing primary care group. So we fit it really nicely and thrived under that model, became the co chair of America's Physician Groups Coalition on direct contracting, and became the advocate within NACOS for that program as they were kind of moving from MSSP to all these other options that CMI was putting on the table. The challenge became, Austin, when the Biden administration replaced the Trump administration. We all know in Washington, everything that the previous administration did, the new administration generally doesn't want to do. So we talked to Liz about doing something that led to ACO REACH and introduced the concept of equity into the model. And that because the Biden administration was stressing equity as a big part of their health agenda, and they really had no program to put out there. So we said, you know what? If you incentivized us to go into underserved communities through this model, I'm sure we would all jump and run and do it. And we did. It was a good movement, and it led to ACO REACH thriving, as the last results proved, 2.5 billion savings in 24, big numbers, a billion back to the government and a billion into the private sector investment. Pretty remarkable numbers, showing that primary care led ACOs had the most success, documented through lots of work by um, GAO and OMB and others. Challenge going forward was that it was tarnished on the progressive side of things. And now the Republicans who were in favor of the program because they kind of grew up in a Republican think tank movement, if you will, were concerned about lots of the benchmark issues and the nuances of the program. So the bottom line is now we have a new model called ACO LEAD, which is where the ACO REACH people will go.
We can go ahead and jump into kind of the meat of things here. Last week, KFF and Peterson released an analysis on, I believe it was 77 insurers that put the median proposed 2027 ACA increase at about 14%. That's on top of roughly 20% this year. From where you sit, what's driving the second straight year of double-digit hikes?
It's really more to me on the delivery system side, which if the ACO movement and the MA movement could really be the drivers of the change, I think we'd be better situated to not have these increases. But the challenge is that fee for service still is in a pretty strong position. Um, the way that hospitals create a pricing structure and the way that CFOs in the inpatient side of healthcare seem to be able to adapt really quickly to how they make money in the models um, is something that we have really struggled with because you could save the money on the primary care side. You could manage utilization more effectively. You can manage cost more effectively to garner savings. But when the hospitals dominate a market to the point where you're paying 100% of Medicare or more, it's a struggle to make that work economically. So you have to cut utilization, but you have to do it within the quality guidelines that are now part of the program. And sometimes that could be a real struggle. And I think the organizations that have struggled the most have dealt with that issue by having a single dominant hospital system in a market, controlling pricing, and they have had to play in that, coupled with drug pricing. Not that the ACOs are paying much for the drug, but we got crushed on fraud and abuse, as you might have covered. I don't know if you've been aware of skin substitutes and catheters on the DME side were really problematic for the ACOs. For the MA plans, not as much because they control authorizations. In the ACO program, not as much, and people can go in and out of the system. And the skin substitute issue was a really good example of people showed up at people's houses, told them that the doctor had sent them, authorized a cubic inch of skin substitute, charged ridiculous amounts of money. But when you talk about cost, I'd say inpatient cost, hospital, post-acute were are big drivers. Specialties still remain big drivers, and primary care led is the only way you really can, drive innovation and change. And I articulate this not only in everything I say and talk to people about, but in my book, I lay this out as a foundation of how moving forward, or everybody in America should have access to primary care led teams. And these teams are more holistic, and they're the ones that manage the dollar. And you and your primary care physician who leads the team manage, navigate through the system together. And you're you're the one, saying, I'm partnering with you, doctor, lead me through it, ask the right questions, use AI, do all the right things. Well, it's not just the insurance companies, it's the insurance companies really are passing through the high cost from the provider side. So incentivize providers to share in savings seems to be a very workable model, especially if the primary care docs lead it. If the specialists lead it, not so much. And the payment to specialists should be through bundles.
The argument that paying for volume, that's more visits, more procedures, that pushes total costs up. Do you buy that as a driver of what's happening to premiums? And if so, how would you change that model?
It would be the number one thing I would change in the healthcare system is remove fee for service. Fee for service incentivize transactional care. And honestly, transactional care is kind of like going to buy something in a retail store. I want that, I want that, I want that. I buy, I buy, I buy. But nobody is watching me and coordinating all of what I'm buying, and do I need it and is it the best for me? So to me, the primary care doc should be that when it comes to the healthcare system, because you as a consumer really are limited in your knowledge what you're going to know. You go to Google, you go to um, any of the AI bots, and you kind of come up with, all right, this is what I think I have. Then maybe you do a telehealth visit with your doctor, more likely not, and then you think you know the solution.
Value-based care has been promised the promise fix for well over a decade. Um, why hasn't it bent the cost curve yet? And what would tell you that value-based care is finally working?
I think the biggest reason it's working, the biggest evidence that it's working now is look at the REACH numbers. $2.5 billion in savings, millions of people now in these programs, and they are comfortable. They're getting used to it. This is a monumental shift to go from fee for service to value-based initiative where doctors are no longer getting paid per order or per transaction or compromising what they do because of incentives, but they're now actually moving towards, you really don't need to come in for that. We could do a telehealth visit and it's easier for you, it's easier for me. And I think technology will enhance it and move it forward because both you and your provider, you have to be a team to match the need for your not only your sickness but your well-being. And we have to really move to a system of treating well-being and mental health and physical health and overall health in the context of you as a human being and who's going to care for you and manage you through the challenges of everyday life, stress, lack of exercise, processed foods, all of the too much screen time, all of the bad things are causing, you can't separate mental health from physical health. And when you combine the two and put it under primary care and then change it from fee for service to incentives to value, I think we move the whole needle forward as a public policy for the country, which we've done this somewhat, but we haven't done it as a full commitment of the US government behind moving from fee for service to value-based care.
That medical economics, a big part of our audience is independent primary care physicians. A lot of them in independent practices, smaller practices. Um, for a physician like that, moving to a value-based arrangements often means taking on financial risk and more administrative work. What's realistic for that physician, and what do they need to have in place before they can make that jump?
Really great question. And what I've watched is that primary care offices can't manage this on their own. There's just too much stuff and too much in a day for them to actually have a balanced lifestyle. You can't work all day seeing patients and then go home, have dinner, and then spend the next 3 hours away from your kids, away from your spouse, and do paperwork to be compliant for the day. There's got to be a better way to do all this. And I don't know if it's going to be in the EMRs being more amenable to, having things at time of service documented in a way that takes the load off of the primary care doc. But there's way too much work, and then they have to hire people to do more of the work, and then their economics really don't fit for that. So honestly, this model of value-based care, when they get a capitated payment based on a population they serve that's risk adjusted, really should give them the cash flow to hire the amount of people they need to be compliant, to manage the patient load, and to use appropriate, people to the top of their licenses. So nurses to the top of their license, nurse practitioners to the top of their license, the doc overseeing, more and more people and having a patient friendly approach, and the patient being fully engaged, documenting their wellness as well as treating their chronic conditions. This is all doable if the economics can match, and transactional fee for service can't work. It won't work over time. I've watched doctors, Austin, who would say, poo poo, I'm not doing that. I'm 60 years old. I'm in fee for service my whole life. You want me now to go to a new system where I'm at risk? I don't want risk, blah, 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 blah. And then I'll tell you the biggest thing I've seen are the 60 and 70-year-old docs who really don't want to give up their practice, but it's getting too overwhelming for them. So they bring in an associate, say, here, you can have the practice over time. Let's move to value-based programs. They start doing it. The young guys love it initially, and young gals love it initially. They struggle when they get some resistance from specialists and hospital systems in their communities. And then it comes where the 60, 70-year-old doc says, okay, I want to sell the practice. And the young guy goes, okay, I would love to buy it, but I can't buy it. I don't have the money. So the hospital can help me buy it. And then I become captive to the hospital. And I can tell you that at a place like VillageMD, when we were in our prime and we were hiring primary care docs all over the place and buying practices, we bought a lot of practices from docs who sold them to hospitals. And then the hospitals made their life much more difficult. They now had on call, they had things they'd never had to do before, and they were salaried and they hated being salaried. So there's a movement that's in front of us called value-based care. If we put the right bow around it, we design it with the physician in mind, with the consumer in mind, make it patient-centric and physician-centric, primary care specific. I believe we can, I think the two doc caucuses are ready to blow the old stuff up, put the new stuff in, and let's go to town. And I think that the current CMMI, I've been impressed with Abe's ability to understand the private sector's role and the role of government and how it can come together and collaborate to become a better healthcare system for the country.
Is there anything that I didn't get to ask you that you wanna share with the audience?
Well, I do have a book out called The Zen Lobbyist, A Mindful Approach to Transforming Healthcare, where in my case, Austin, I had three episodes, one of anxiety that led to a state of depression that led to um, needing a solution, and drugs weren't a good solution for me it's the first thing that psychiatry wants to do is give you a drug to make you feel better. But I did the hard work. I found yoga, meditation, and mindfulness, and I incorporated those into a daily practice and focused on things like compassion, gratitude, love. It became my antidote for stress. Because if you're an entrepreneur in this world and you think you know all the answers, A, you don't, and B, you're going to have stress working on your body and you're not even going to be realizing it at times, and it's a killer over time in some physiologically, whether it's cardiovascular or from a mental health perspective, just takes you out of being able to function. And we have to be mindful of how we do that. So I incorporated all of those strategies into my day-to-day living, and I was like had a new life at the age of 50, and I'm now 70. And wow, that was amazing that I could do all that. And I did through these practices. So writing the book was my kind of love letter to Congress that, hey, we're all human beings. We all care about the same things at the end of the day. We want to love our family. We need to love ourselves. We care about the world around us, and we want to make it a better place when we leave. So, how do we do this together? And here are the techniques I've used. Maybe they would be beneficial to you, or you find if meditation doesn't work for you, maybe it's prayer, maybe it's, showing more love to your family, maybe it's, not working all through the night, every night, and maybe it's spending more time with loving the people around you. So simple things like that. And then I incorporate that into how I used it as law in my lobbying world. The last part of that I want to just highlight is I do a lot of work with Patrick Kennedy. I work at an organization called Healthsperien, and I do consulting from there. And we have a lot of coalitions. Patrick is head of a coalition on mental health, and the Kennedy Forum presents a lot of. They just had a program on social isolation and loneliness, which is a huge issue in this country. And there's now a foundation around social isolation and loneliness that is shining a light on how powerful this is as a problem in this country. Bottom line is, Patrick showed me that mental health is also about addiction, and addiction is not just chemical addiction, it's also addiction to things like betting apps and social media. And his fear is that if we don't get a handle on these issues, then bad actors can come in and take control of more and more Americans through these algorithms and these apps, and let alone drugs and things like that, that can, really dull the creativity of the youth of America, which would be a terrible thing. So I never looked at it from those eyes before, but he's enlightened me and it makes a lot of sense. So it's become a bigger issue in my world too, to focus on. And I'll leave you with three words I like to use with that. Silence is strategy, compassion is influence, and gratitude is renewal.